Fundación Cana brings you the following article. Pain and Cannabis, Evidence or Experience? By Carlos Goicoechea, Professor of Pharmacology, Rey Juan Carlos University, Madrid, Spain. Recognized as a chronic disease in the latest international catalog of diseases by the World Health Organization, pain can be defined as primary or secondary, which means it can be the consequence of a demonstrated physiological alteration, secondary, or have an undetermined origin, primary. However, no matter whether it's primary or secondary, there is growing certainty that pain, in particular chronic pain, is a disease, and as such should be treated individually while, of course, continuing to treat the pathology that caused it. The approach to chronic pain is not easy, and it can't be. It involves a disease in which not only physiological but also psychological factors converge. Economic, social, and cultural factors also play a role. All this means that if all these factors aren't addressed simultaneously, it is very likely, almost certain, that the final result will leave much to be desired. But it will not be easy. We are not prepared for this. We don't have the habit, nor the strategy, nor the necessary tools to approach pain from all these diverse perspectives. To understand the complexity of the approach and treatment of pain, we have to briefly review the nociceptive system and the pathophysiological changes that occur as a consequence of a nociceptive stimulus over a longer period of time. Distinguishing between pain and nociception is very important when it comes to understanding our ability to modulate pain from a pharmacological standpoint. The nociceptive system and pain. The presence of a nociceptive stimulus tells us that something is not working properly. That something can be external, such as a puncture or burn, or internal, for example, a fracture or infection. In both cases, the body has a highly specialized system that detects, transmits, and modulates to some extent this information, alerting to a potentially harmful stimulus. This is the nociceptive system. It is composed of neurons that send the message to the spinal cord and from there to the brain. In the brain, the location and intensity of the stimulus are identified. It acquires its emotional components, and when it reaches the prefrontal cortex, the information is interpreted and becomes pain. There are endogenous pain control systems, neurons that are capable of modulating the transmission of the nociceptive signal to decrease the intensity of the message that reaches the brain. These systems are located in the spinal cord. Some are part of the local spine circuits, but in other cases, they are pathways that are generated in the brain, neurons that descend to the spinal cord to stop nociceptive communication. These descending pathways cannot be activated voluntarily, but they can be stimulated, for example, by moderate physical exercise, positive expectations, and psychological training. The nociceptive system reports any situation that can be harmful and dangerous to the integrity of the individual, which is why it provokes an unpleasant response so that an animal or person can escape, flee the situation, and protect itself, or avoid certain behavior in the future. It also creates a memory to avoid someone from putting themselves in that same situation again. Pain and memory always go hand in hand, for better and for worse. Pain is like an alarm. Pain relief systems are never or almost never 100% effective because the maintenance of pain is essential to our survival. It reminds us that there are things that we must avoid or fight. Furthermore, if the alarm signal does not switch off, everything will focus on amplifying the activation of the nociceptive system, exaggerating the information and amplifying its transmission to further turn up the alarm. That is when a series of changes occur that transform pain into a disease in itself, in a process that evolves independently of the cause where it originated, and with the ultimate goal to increase the amount of information that reaches the brain, where it is interpreted in the prefrontal cortex. When pain becomes chronic, the nociceptive system is completely modified. The pathways, neurons, responsible for transmitting nociceptive stimuli increase their effectiveness, and the endogenous systems responsible for controlling this information become less efficient. Also, the emotions generated in the limbic system are exaggerated, amplifying the entire system. Chronic pain patients don't experience their pain or their surroundings in the same way, which of course changes their life significantly. Therefore, the pharmacological approach to pain must take into account the entire complexity of chronic pain and adapt to its characteristics, type of pain, duration, location, etc. For this, we can use anti-inflammatory analgesic drugs, paracetamol, opioids, antidepressants, not used here to treat depression but to enhance the downward modulating systems, and neuromodulators. The choice of pharmacological therapy has to be personalized and adapted to the type of pain and the characteristics of the drugs, but also to the patient, of course. The beneficial effects of pain treatment may be the result of its effect on the nociceptive pathways, peripheral effects, or on the patient's perception of these stimuli and how they cope with the experience of the pain, central effects. The endocannabinoid system and pain. The endocannabinoid system is an inhibitory neurotransmitter system. This means it's composed of substances that interact with receptors capable of decreasing the activity of neurons. These are substances, such as anandamide or diacylglycerol, that are generated on demand and decrease neuronal activity. The endocannabinoid system is present throughout the entire nociceptive system. There are CB1 cannabinoid receptors on nociceptors and on spinal and brain neurons. That is why, ever since its discovery in the middle of the last century, attempts have been made to stimulate the system pharmacologically to reduce the transmission, nociceptors, and interpretation, brain, of pain. In addition to being present in nociceptive neurons, we find cannabinoid receptors, CB2, in the cells of the immune system. These cells are activated when they detect harm or danger, and that provokes an inflammatory response and generally creates a greater nociceptive response because they stimulate receptors located in the nociceptors and always with the goal of associating harm and pain to generate a harm avoidance memory. There is also the neuroimmune system, the glial cells, microglia and astrocytes, where cannabinoid CB2 receptors are also present and are responsible in the central nervous system for neuroinflammation that contributes to the chronification of pain. Right from the beginning, the use of cannabinoid agonists in lab animals has demonstrated that the activation of the endocannabinoid system produced analgesic effects, anti-nociceptive to be more precise. Animals treated with these drugs showed a high pain response threshold, which means they took longer to respond to pain. This was verified in different models of animal pain, acute and chronic, nociceptive, and neuropathic. From the start, it was also found that stimulating the endocannabinoid system caused psychoactive effects on the brain, identified as those induced by the recreational use of cannabis. It is precisely these effects on the brain that have posed a problem when developing cannabinoid drugs for pain treatment. The treatment of chronic pain involves continuous drug use to try to lead a normal life as much as possible, so the psychoactive effects can be a very relevant problem for chronic patients when using these drugs. However, there is an interesting possibility to pharmacologically modulate the endocannabinoid system without causing psychoactive effects, by affecting the CB2 receptors located in the immune system and the glial cells on the spinal cord. These pro-inflammatory cells that also contribute to chronic pain can be effectively inhibited with CB2 receptor agonists. Although as of today, no synthetic cannabinoid agonist is proven to be a highly effective analgesic, at least at the clinical level, there is much interest in developing selective cannabinoid agonists that can deliver a good analgesic result with few side effects, because they selectively target either the CB2 receptors or the CB1 receptors without having access to the central nervous system. Cannabis and pain. One of the first medicinal uses of hemp was in pain treatment, and it is still used today. One of the first recommended uses for medicinal cannabis is pain treatment, although there is still some controversy, at least in some areas, about its effectiveness as an analgesic treatment. The use of the plant in pain treatment has become widespread in recent years. There are numerous forms of consumption: smoking, inhaling, ingesting, topical application in the form of a cream, and a variety of plants are used with varying concentrations of active ingredients. This makes it extremely difficult to be certain of how cannabis works on pain and to differentiate whether it actually acts on the perception of pain itself or in the way someone perceives and interprets any external sensation. The method that allows us to verify if a medicine, a treatment, or a technique is effective in treating a pathology is a clinical trial. This is a required step to confirm that the observation can be applied to a much larger group of patients and to enable the development of treatments with broad therapeutic use and few or acceptable side effects. Although the situation is changing rapidly, there are not many, at least not enough, well-designed clinical trials that allow us to analyze the real effect of cannabis in managing different types of pain. As already mentioned, differences in the formulations, the type of patient, the duration of treatment, and other factors and variables. For example, it's not the same to assess only the subjective intensity of pain, but quality of life as well. Subjective intensity of pain, but difficult to draw universal conclusions. We are not conducting a review of every study published so far. Those considered most useful or relevant are included in the bibliography. However, we can put forward a series of conclusions. There is insufficient evidence to use cannabis in acute pain situations, although low-quality studies have indicated that its analgesic effects are superior to a placebo. A higher number of studies have been published on chronic pain, and their conclusions indicate that cannabis can be used in those situations in which satisfactory results have not been achieved with other treatments for which more evidence is available. It is more effective than a placebo, and although usually not serious, we cannot neglect the frequency and characteristics of the side effects. Frequent side effects include sedation, confusion, and disorientation, among others. One of the types of pain that causes the most suffering in patients is neuropathic pain or nerve pain, which is difficult to treat due to the complexity of its pathophysiology. In this type of pain, cannabis produces a moderate analgesic effect with side effects that can be tolerated in most cases, depending on the severity of the pathology. In cancer pain, as in other types of pain, the efficacy is moderate and still disputed, although its use may be beneficial because it also reduces some of the side effects of chemotherapy in cancer treatment, such as nausea and vomiting. Countries where medicinal cannabis is already being used for the treatment of pain propose its use in carefully selected patients, always under strict medical supervision and with proper knowledge of the origin of the product used. In conclusion, there is clearly a void that can be filled by the use of cannabis and cannabinoids in the treatment of chronic pain. In situations where pain is not reduced with other drugs or the side effects of these drugs are unacceptable for the patient. Efficacy depends highly on the patient, the pathology, and the product used. We cannot draw general conclusions at this time. Side effects, although generally not serious, are not uncommon and affect the cognitive sphere. These require more well-designed studies that not only compare the use with placebo, but also with other treatments to better define a more precise scope for its use. This article was brought to you by Fundación Cana.